All right, Alex, are you all set?
Yes, I am.
Okay, I'm gonna start letting everyone in.
Good morning, everybody. Thank you so much for joining us today. We are just going to give it a couple more minutes just to make sure everybody is getting in. I know there's a Zoom update going on out there, so some people may be running into that. So we will get started in just another minute or so. All right, I think I will get us started today just so we are mindful of everybody's time. Thank you so much for joining us today. We are so excited to have many of our members joining us for this webinar on cervical cancer prevention, screening, and treatment. Today, this call is being recorded, so the recording and slides will be made available sometime shortly after the presentation today. If you are experiencing any sort of technical difficulty throughout this presentation today, feel free to use the chat for assistance or the help options within Zoom. And before we get started today, I have just a few housekeeping items to go over. Firstly, we are delighted to have so many new people join us today, along with our already existing members. For those of you who may not be as familiar, we are the Wisconsin Cancer Collaborative, Wisconsin's statewide comprehensive cancer coalition comprised of over 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. If you are not yet a member, we would love to have you join. Membership is free, so if you are interested in joining, you can do so at the link below. And I believe we will drop that into the chat for you to follow as well. Here is the agenda for today's call. We are first going to hear from the Wisconsin Well Woman Program, where they are going to give an overview of what the program is and the services that they offer. We are then going to hear a presentation by Dr. Denise Uyar from the Medical College of Wisconsin. We will have time for a question and answer session at the end. And also stay tuned after that for some really exciting Wisconsin Cancer Collaborative announcements. And with that, I am pleased to introduce our speakers from the Wisconsin Well Woman Program. Today, we will hear from Nicole Peplinski, the Case Management Coordinator for the Well Woman Program. We will also hear from Lena Sutton, Patient Navigator for Central, Western, and Northern counties in rural areas located at Marshfield Clinic. We will also hear from Don Shelton Williams, the Patient Navigator for Southeast Wisconsin out of Advocate Aurora. And we will also hear from Anna Karina Cuellar Montez, Patient Navigator for Wisconsin Southern counties out of UW Health. And with that, I will turn it over to the Well Woman Program.
Good morning, this is Nicole. Thank you so much for that nice introduction, Alex. And thank you to the Wisconsin Cancer Collaborative for this opportunity to share information about our program on your platform. Our agenda today for today's presentation will include an overview of the Wisconsin Well Woman Program, followed by information on the following topics related to patient navigation component of our program. So we're going to look at what is patient navigation, what women are served through our patient navigation program, how patient navigators can help, a little bit about rural patient navigation, what our patient navigation outreach program looks like, and how clients can get connected. Next slide, please. So I'm going to give a little quick overview of the Wisconsin Well Woman Program. The Wisconsin Well Woman Program is a breast and cervical cancer screening program serving Wisconsin residents, ages 45 through 64. There is an age exception for clients 35 to 44 that present with symptoms, or for clients that are 65 and older that are not eligible for Medicare Part B or cannot afford the premium for Medicare Part B. The clients we serve are uninsured or underinsured, and there is an income requirement at or below 250% of the federal poverty level. The Wisconsin Well Woman Program has been providing services through the Centers for Disease Control and Prevention's National Breast and Cervical Cancer Early Detection Program since 1994. WWP is administered by the Wisconsin Department of Health Services Division of Public Health in Madison. Next slide, please. So our primary goal in WWP is to increase the morbidity and mortality of breast and cervical cancer through routine screening services through residents in the state of Wisconsin. Next slide, please. Our provider network is made up of 40 organizations, which include health systems, federally qualified health centers, rural health centers, and hospital outpatient clinics that provide services for WWP clients. So the providers in our network must be Medicaid certified to participate, and we have over 400 provider sites in the state for clients to receive services at. Next slide. So the Wisconsin Well Woman Program covers services for breast cancer screening and cervical cancer screening only. So I've listed those here on the slide. This is a summary of the services we provide, but it does not include all of the services. But generally, routine breast care screening services include an office visit, a clinical breast exam, and a mammogram. And if that routine screening is abnormal, our program can cover diagnostic services for follow-up, such as the diagnostic mammogram, ultrasound, and biopsy. The Well Woman Program can also cover annual screening for clients that are considered at high risk for breast cancer. Our routine cervical cancer screening services include an office visit, a pelvic exam, a Pap test, and an HPV test. If a routine screening there is abnormal, our program can cover diagnostic services such as a colposcopy with or without a biopsy, a LEEP, or a cold knife conization. Any client that is enrolled in our program, or most clients, I should say, that are enrolled in our program and diagnosed with breast cancer, cervical cancer, or a precancerous lesion of the cervix may be eligible to receive treatment through the Wisconsin Well Woman Medicaid program. The Well Woman Medicaid program is a fee-for-service, full benefit Medicaid program. Next slide. The data shown on this slide represents the number of clients that received mammograms and Pap tests over a 5-year period from 2017 to 2021. And the bar that I have edged in white here represents the year 2020. And our program seen the same decrease in screening services as the nation did due to the COVID-19 pandemic. Our screening goal for this current program year is to screen 4,000 clients. Next slide. So we have 3 different components of the Wisconsin Well Woman Program that connect clients directly to screening services, and our coordinating agencies are the largest and main component that makes that connection. We have 14 local agencies across the state that provide full program coordination. Each agency is staffed with a lead coordinator and a backup coordinator. Our program coordinators are responsible for determining client eligibility and enrolling clients into the program. While determining eligibility, our coordinators will also determine whether a client may be eligible for Badger Care Plus or Marketplace insurance and will refer appropriately for a more comprehensive healthcare coverage program. Each client receives case management services from the first encounter through routine screening, as well as abnormal follow-up screenings through diagnosis. Our coordinators provide support to the Well Woman program providers in their jurisdiction as needed, and are responsible for program outreach and education on breast and cervical cancer prevention. Next slide. Each of the 11 federal recognized tribes in Wisconsin participate in the Well Woman program as a coordinating agency as well. Each tribal agency site has a coordinator present to determine eligibility and complete enrollment. Our tribal coordinators focus mainly on breast and cervical cancer education and prevention versus client enrollment, as many of the clients they connect with receive preventative health care through their tribal nation. Next slide. The third component of our Well Woman program is our patient navigation program that connects clients to breast and cervical cancer screening. And these clients are a little different than the clients that enroll in our Well Woman program, because these clients do have a source of coverage but are experiencing other barriers to screening. We have 3 patient navigators that are licensed social workers, and they are connected directly with a health system. Our navigator with Advocate Aurora Health covers Southeastern Wisconsin. Our navigator with UW Health covers South Central and Southwestern Wisconsin. And our navigator with Marshfield Clinic covers Central and Northern and Western Wisconsin. Dawn with Advocate Aurora Health will begin the presentation on patient navigation for us. Next slide, please.
Okay, actually, I'm going to turn this over to Anna Karina, who will talk about this section, and I will follow her. Thank you, Nicole.
All right, thanks, Dawn, and good morning, everyone. So we're going to start to talk about what is patient navigation. So many people ask me, what is a patient navigator? So this is a kind of unique role because we meet patients where they are at. So what we help with can be different for every single one. But if we really want to give a summary, we want to remove barriers of healthcare so people can access or get through the health system. And also we provide patients with resources, whatever these resources will look like. Patient navigators can assist patients with breast and cervical cancer concerns at any time point, from screening, the diagnosis process, treatment, into survivorship. We also focus on non-clinical challenges. That means the non-medical factors that influence health outcomes. Addressing social determinants of health appropriately is very important. We use a social work assessment where we ask patients for any challenges or barriers that prevent them from receiving breast and cervical cancer services. And Dawn will talk more about this work assessment. Also is patient-centered and very individualized. So sometimes we meet patients and these specific patient maybe only need 1 or 2 touch points and they are good to go. Other times we help patients from the first screening through every single step. Also, it's very important the quality of relationship we establish with patients. So gain trust is very important, especially if we are working in rural areas and with minorities. We also help to address health disparities in breast and cervical cancer. Some of the navigation activities that we do, are different, but the focus is prevention and early detection. And also we can also help, patients with the translation of breast cancer information, or if they have any language barrier, we can help that too. We can facilitate appointments, healthcare access and coordination. So different things. Next slide, please. So what patients are served through the patient navigation. So all women resident in Wisconsin, also women referred by a Wisconsin Women Coordinator, low income uninsured women, Medicaid clients, Medicare beneficiaries, or any uninsured women that are not eligible for the WWP. Also any women that experience barrier to get screening services. So many of our patients are insured and underinsured, and we try to connect to this service, to these services or any kind of insurance that they need. We also can help with transportation assistance, whatever it is to find a ride for them to go to the hospital with gas or whatever services that they need. So now I'm going to turn over my colleague, Dawn.
Thank you, Anna Karina. Next slide, please. So how can patient navigators help? Anna Karina talked a little bit about the assessment and screening that we provide to the clients that we work with. It is assessment and screening that looks at those non-clinical challenges and barriers that women may encounter in getting either routine breast and cervical cancer screenings or diagnostic screenings. So the tools that we use are culturally responsive tools. We also assist in our patients or clients and navigating the healthcare system. As you're aware, healthcare systems are large and at times can be very confusing, but have a lot of resources that even patients may not be aware of. Another important piece, we help them to navigate within their communities, within their neighborhoods, those community systems that impact maybe daily functioning of the patient and her family. Assistance with insurance coverage. We work with women who are uninsured. So screening for Badger Care, Medicaid, or insurance through the marketplace or the Affordable Care Act exchange. We help navigate our clients through those systems. And we refer to the Wisconsin Well Woman program for breast and cervical cancer screenings. We collaborate very closely with the coordinators in the counties that we serve. Another issue that may come up that we can assist with is helping clients around assistance and with billing issues. Clients receiving Well Woman program screening services should not receive bills. So sometimes this happens, and then we can help address those issues within the healthcare systems. Next slide, please. Here are just some other things. I'm not going to go through all, but we do provide health education on the importance of breast and cervical cancer screenings. One that I think is very important is the emotional support that we're able to provide to the clients and patients we work with. We also look at different resource referrals to help deal with those challenges and barriers that may be preventing women from getting those screenings. And those run from a gamut of, mental health issues, transportation, sometimes childcare. We look at those supportive resources in the areas of mental health. Integrative medicine is another area, as well as looking at nutrition and our clients' needs around spiritual care. And again, the community connections are very important. to clients, and we as patient navigators help to connect to some of those important resources within the areas that we serve, such as Gilder's Club, ABCD, which is after breast cancer diagnosis, which provides women that's diagnosed with cancer with mentors who are actually breast cancer survivors, and Susan G. Komen, as well as the Aging and Disabilities Resource Centers in our areas. Next slide. We also do help with case management, and I'm also going to talk about care coordination within the healthcare systems, working with our patients to make sure that we're working with our healthcare teams around coordination of services. I talked about mental health. We do also around financial and employment assistance. Lodging and transportation, Anna Karina mentioned that. And one of the things that actually comes also around the emotional support, having those conversations with women that may be experiencing fear and anxiety about screenings, and then helping around advocating, improving maybe communication between the client and her healthcare provider and team, and then again, dealing with any family issues or childcare issues. Next slide, please. So I am going to turn it back over to Anna Karina. Unfortunately, our other colleague is not able to join us today, but Anna Karina is going to talk about rural patient navigation and how this works, our work helps women in rural communities. Anna Karina?
Thank you, Dawn. Okay, so community outreach is very important of what we do as a patient navigator. And one of the ways that this is helpful is that we try to focus in areas that are rural as well, because we find that they have very unique challenges. So that way we try to reach women that maybe they don't have connections with the health system, or maybe they have other barriers in place, how we have been mentioned before. Working in the community is working with the community. We can do it by participate in different type of events or ways that we can get involved. Later in this presentation, you will see some examples of different events that we participate in the past, and can be anything for doing an event or coordinating any kind of events through the health system. For example, this month, I participate in different cervical cancer screening events when I represent the Wisconsin Well Women Program and also the patient navigation services. So other times, we also can collaborate with different entities in the community, can be through working with the free clinics, or maybe collaborate with the libraries, food pantries, church, school, farms, any organization, any place that we can identify that we may be able to outreach the population of women that we think that will be benefit for our services. Our goal with the outreach is important because we want to increase the number of women that are getting their breast and cervical cancer screening, because we know if we do this, we are helping bridge the gaps among rural women in relation to compliance for cancer prevention and detection. We can also help these women in making appointments and help them bridge the gap between the healthcare providers. We also play an important role in that because abnormal screenings can be followed up with appropriate care. How I explained, this can be in different ways. We can help them to make appointments for diagnostic mammogram, biopsy, colposcopy, or anything that they need for them to initiate a treatment. And also, rural communities have different layers for care and unique challenges, because it's very common that these communities not have all the resources that we have, in the cities. So some communities have very limited resources. And one of the things that always, come up is lack of transportation or access to public transportation, because there is no public transportation at all. And also financial limitations as well. Limitation in access to internet is one too. Sometimes we forget that not everyone have access to high-speed internet. So that's can be a barrier for some people. Also, I encounter people that cannot read or write. So kind of work one by one is very important, because working with these rural women can be very challenging. Also, we try to engage the community through different, events that we try to plan in the community, and that help us to foster trust in the community that we serve. So we found that more the community trusts us, they will look for us. They will talk to us about the issues and the barriers that prevent them to get breast and cervical cancer services. So establish that trust is very important. And also we can help in exploring different resources or charity programs in the between the local health providers. Next slide. And I kind of, talk a little bit about this. All right. So, Dom. Oh, next slide. I'm sorry. Okay, so other part of what we do is a cervical cancer education. So for our educational events, we use different handouts and information sheet about breast and cervical cancer. This is an example of one of them that we use. And we use these materials to start conversations about the importance of early detection. Next slide, please. So this is some examples of one of the outreach educational events that I haven't participated. So in the pictures, you can see like working with community, different free clinics in the area. Before COVID, I was able to talk to patients while they were waiting in the waiting room. But now because of COVID, just work one-on-one when they're waiting to see the provider. Also, in this event, in this month, I have one event called Papapalooza. It's a very, a very recognized event in the community that we do every year for women that cannot get pap smear because they are not eligible for insurance for the Wisconsin Women Program, or they or they really no one, some of these some women's, they don't want to get any benefits from the state, so they come to this event. Next slide, please. Also, this is a different pictures of how we educate women. Like we meet one-on-one, we can have a resource table in the clinic. We try to outreach them in different ways. Can be visual, can be in different ways. Next slide, please. Also, we meet with them in stores, in the library, providing education. We participate in different events for minorities. In one of the pictures, I participate in the annual Pride in the park in Platteville. Also, I collaborate with a clinic in Platteville, and we have this January awareness, month event, and where we invite, women to come to us and help them, with enrollment in the Wisconsin Women Program, or if they were not eligible, so that organization could provide also some services. Next slide, please. So we participate in different health events, resource events. Also in the rural areas, I collaborate with one of the free clinics and we go to some farms and I help them, if they're eligible for the Wisconsin Women Program, help them with the enrollment form or provide education if they are eligible for insurance. So I can help them that so they can get their screening services. Next slide. Okay, so now Dawn will talk a little bit more about her events in her area.
Thank you, Anna Karina. Community outreach is extremely important as our role as patient navigators. We do outreach, in-reach within our healthcare systems, but we also want to make sure that women within the community are receiving information about the importance of getting their breast and cervical cancer screenings. I serve more of a, well, actually an urban population. So here are some of the events that I have participated in. I also collaborate very closely with our community outreach, our senior community outreach coordinator for our Wisconsin Cancer Service line for Advocate Aurora Health. So in the second picture at Puerto Rican Family Festival, this is the event that actually she and I participated in to increase awareness among Latina women in Milwaukee. The other event that happened really a year after COVID was actually held at one of our clinics that serves primarily African American women and kind of the population. It's on kind of the northwest side in Milwaukee. It was at our Midtown clinic. And it was a resource fair with also the theme around helping to increase awareness around COVID-19 and the importance of getting the COVID-19 vaccination. Next slide, please. So I am sharing again, our other colleague, Lena, was unable to attend, but here is an event that the first picture that she participated in called the Empower Me Outreach event for the Marshfield Clinic in Eau Claire. This happened in October. So this was during Breast Cancer Awareness Month. And then Aurora Sinai Medical Center, which is actually one of our campuses that's located in the inner city of Milwaukee. We had a very fun event for the community for Halloween. It was called Trunk and Treat. And we provided information. We dressed up in costumes, the staff did. We provided candy to the community children, but we also provided information to caregivers and parents that accompanied their children. This was an awesome opportunity to share more information about the patient navigation program through Wisconsin Well Woman program, as well as the Wisconsin Well Woman program preventive screening program. So this was actually done in collaboration with our comprehensive breast clinic that's located at Sinai. Next slide, please. Here is just another, these are from Lena, some of the activities that she also participated in which Wisconsin Well Woman bags with educational materials were provided to these game attendees at the Merrill Football Pink Nights activities in 2021 and 2022. Next slide, please. So we are going to quickly go through, we've talked about patient navigation, how it's beneficial, kind of what we do. So we want to provide you actually scenarios on how we work as patient navigators. So I am going to start off with Miss Carmen, and I'm going to show how the program works around patient navigation for breast cancer. So Miss Carmen, she's an African-American female, 36 years of age, diagnosed with breast cancer in 2017. She lost her Medicaid benefits when she began working in 2018. At the time when I started working with her, she was working 6 days a week, 8 hours per day, but could not afford the marketplace insurance. She did have a history of mental health, anxiety and bipolar depression, and ran into the challenge of being unable to afford medication or to see her long-term psychiatrist when she lost her Medicaid benefits. This also interrupted cancer treatment. So that was one of the major fears that the healthcare team had, that there was going to be somewhat of a kind of an interruption. And that's why they contacted me. Next slide, please. So this is how patient navigation works. So around care coordination, I worked with the healthcare team at the Aurora Sinai Medical Center, the Vince Lombardi Clinic. For resource linkage, Miss Carmen was actually born in another state and had lost her birth certificate. So this created challenges for her in regards to applying for Medicaid actually through the Wisconsin Well Woman program. I explored resources in the community as well as providers in the community to assist her in getting a copy of her birth certificate at a low cost. For resource linkage, I worked with a community provider to assist her in obtaining her mental health medication for a month until she was enrolled and accepted in the Well Woman Medicaid program. Emotional support was extremely important for Miss Carmen during this time. So frequent contacts, calling, checking, see how she's doing. I'm just having conversations with her to kind of decrease some of the anxiety she was experiencing. And the outcome from the patient navigation services, she resumed her cancer treatment. She was able to get the medication for her mental health needs. We got her birth certificate and she was able to enroll and receive Medicaid services through the Wisconsin, the Well Woman Medicaid program. Next slide, please. So now I'm going to turn it over to Anna Karina, who is going to talk about patient navigation services and helping with a patient around cervical cancer screening.
Okay, thank you, Dawn. So I will talk about this patient that I have. So this patient that Miss Amanda, of course, not her real name. She was a Hispanic female, 40 years old. I got the referral through the Mexican consulate in Milwaukee. So she was living in a very rural area in Wisconsin. So when I contacted her, she told me that she was experiencing some issues, women issues. And I was able, through the social work screening, see that she didn't have insurance, so but she was eligible to enroll in the Wisconsin Women program because of the guidelines. So she was enrolled, so she was able to get her screening and diagnostic services through the program. So she got a diagnosis of stage 3C1 of the squamous cell carcinoma of the cervix in 2020. Later in 2002, we found that this was metastasis and went through the neck, abdominal, the thoracic, the lungs, the liver. Also, other information about the patient is that she worked part-time for a cleaning company. She also was married with 5 children, age 10, 18. Her husband at that time was working because he had an accident at work. So she was kind of the caregiver of for the family as well. And that was kind of the things that she told me why she come, ask for help, like 4 or 5 years after she started to experience some of the issues that she have. She also not have health insurance, and no was any way for her to get any kind of insurance. So she only was eligible for emergency Medicaid. And she have a lot of financial concerns, also language barriers. She didn't speak English. Next slide, please. So with Miss Amanda, what I did was do some care coordination. So I work with the healthcare team at UW Health Carver Cancer Center. I also help her with different resources. So I help her to apply to the financial assistance through UW Health. And also we explore different resources and grants. And there is a couple that that there is in the slides, such as the Connie Ruth Legacy Fund, Tricia Straub, also some local county cancer collections grants. Also, I help her with transportation, lodging, and peer support. And also with emotional support. So I call Miss Amanda often to check in on her and see how she was doing. And I provide a lot of support and listening. So she always were very appreciative for the calls. And also I refer her to a mental health counselor and a support group in Spanish that help cancer patients in survivorship. So Miss Amanda was approved to receive services through UW Health. Unfortunate after their treatment didn't advance, the cancer advanced, and she passed away last year. And one of the things that I made me to work, I'm passionate and work hard with patients is that, and Miss Amanda told me that she came after, 3 or 4 years that she had these issues because she didn't know what to do and because was so many things going on in her life. So that's what is the importance of early detection and, find out women that really need these services. Next slide, please. All right, so this next is case scenario. So Miss Samantha is a Caucasian female, 49 years old. In 2019, Miss Samantha PAP's test results were abnormal with the results of ASEUs or atypical squamous cells of undetermined significance. In 2020, when she returned for screening, her results were abnormal again with LSIL or low-grade squamous intraepithelial lesions, including HPV challenges. So then Miss Samantha had a colposcopy with a biopsy confirming the changes of her cervical cells were mild or low-grade CIN1. So an endocervical curettage was scheduled as a 3-month follow-up for Miss Samantha, and the results were negative. Also, the patients did not have insurance. She worked part-time at that time, so she had many financial concerns. Next slide, please. So with Miss Samantha, I did some care coordination. So I worked with Miss Samantha and her healthcare team at Gunderson Clinic, Boscoville, and with the Wisconsin Woman Coordinator in her area. So because she was from Boscoville, we want her to be there in her local system. So I help with reschedule appointments, with transportation. That was during COVID-19. So she lost her job, so I helped her to apply with unemployment. I did some referrals for energy assistance program, also food pantry. She needed some dental resources. So it was a lot of, support and also emotional support because her appointments were canceled and she was getting a little anxious about this. But the outcome is that she kept her appointments for breast and cervical cancer and screening, and she's re-enrolled in the Wisconsin Women Program every year. Next slide.
Okay, thank you, Anna Karina, and thank you, Dawn, for the presentation on patient navigation. Due to the sake of time, I am going to end our presentation here with just a couple of notes that we do have some patient testimonials included in our PowerPoint, so those could be reviewed at a later date. And that we want to emphasize the importance of how breast and cervical cancer screening can bring forth that early detection and help treatment for those clients receive treatment earlier if needed. And then we've included some contact information for each of us if you're interested in or need to get a hold of any of the client of our patient navigators or myself. Our contact information is located within this PowerPoint. So thank you very much for attending and listening to our presentation today.
Thank you so much for that presentation. It was some really, really great information. And we are going to jump right into our next presentation, but there will be time for questions and comments after this. So feel free to save those till then or drop them in the chat and we can get to them afterwards. But we are going to jump right in, and I am so pleased to introduce Dr. Denise Uyar. Dr. Uyar is a specialist with the Froedtert in Medical College of Wisconsin Health Network. Dr. Denise Uyar joined the Department of Obstetrics and Gynecology in the Division of Gynecology Oncology at the Medical College of Wisconsin in October of 2004. Her clinical practice includes the care of women with gynecologic malignancies, including uterine, cervical, ovarian, primary peritoneal, fallopian tube, vulvar and vaginal malignancies, and gestational trophoblastic disease. Dr. Uyar's academic interests include research in early and advanced uterine malignancies in the human papillomavirus and its effect on the genital tract. So I am going to give Dr. Uyar remote control of the screen. And so you should be able to advance your slides if you click a few times.
Let me see. Oh yeah, I can use the buttons. Thank you.
Great, thank you.
Perfect. Good morning, everyone, and thank you so much for having me, and thank you for that kind introduction. Again, my name is Denise Uyar. I am with the Medical College of Wisconsin, and I am in the Division of GYN Oncology. And today we'll talk about, although I think a lot of it was covered already, but we'll talk about cervical cancer screening, treatment, and prevention. We'll start with the next slide. Oh, it was working, and now it's not. Hold on. Oh, okay. It does work, sort of. So we'll just start. I think you probably have already the sense of the anatomy, and I think it was a lot in the past discussion, but just in case, just as a review, can you see if I move my mouse or no? You might not be able to see any mouse there.
Yes, we can.
Oh, you can. Okay. So thank you. So this is the fallopian tubes and the ovaries. This is the uterus. If it is kind of cut like a pear, I always tell patients if you cut it like a pear, you kind of can see inside. This would be the uterine cavity, the lining of the uterus. Separate cancer from the cervix. People think that it's all together since it's one, or it seems contiguous, but it is different. The cervix is the lower part of the uterus. It's usually about 4 centimeters in length. And dilates with delivery of infants. And then vaginal canal is similar to skin. It is a squamous cell that lines the vaginal canal along the cervix, and the vulva is the external genitalia. So that's just when we talk about those terms, just so we're all on the same page. And we're going to focus on the cause of cervical precancers and cancers, which is the human papillomavirus. So just as a little background, it is the most common sexually transmitted disease. In 2018, there were 43 million HPV infections in the US. 14 million of those are new, and HPV is a recognized cause of cancer and precancer. It is also not just cervical cancer, it's also associated with other cancers as well. Although it is primarily responsible for the majority of cervical cancers, and in 2022, there are over 4,000 deaths alone from cervical cancer. It's also responsible for oropharyngeal cancers, which are cancers of the back of the throat, anal cancers, penile cancers, vulvar cancers, and vaginal cancers. And also certain subtypes are responsible for genital warts. So the human papillomavirus is just like a flu virus or any other virus. There's over 100 subtypes, but there's probably about a dozen or so that are responsible or related to cancer development. So cervical cancer screening recommendations, we still rely heavily on the Pap test. This examines cells removed from the cervix, enables cervical precancer and cancer detection. So that is a test that's required probably depending on how frequently a person gets it and what the results are. At this point, we don't perform them annually the way we used to. It usually depends on if you have normal results in the past, we can spread them out over 3 to 5 years. The HPV test also is performed with a lot of Pap tests as co-testing, and this examines cells from the cervix for pieces of HPV DNA. So it's a little bit different, these two tests, and they somewhat complement each other. There's some movement to just go to the HPV test alone and not even do the Pap test anymore. But currently, that's not the endorsement of all associations. So right now, we are still doing both. If you're less than age 21, you usually do not start Pap testing. That's a change over the course of even my training. We used to do Pap smears at the beginning of sexual activity for females, but now it's not even done until you're over 21. From 21 to 29, as long as your results are normal, it'll be every 3 years. From 30 to 65, also if your results are normal, you'd have a Pap test every 3 years, or you could do co-testing, both of them together, every 5 years. If you're over 65, you talk with your doctor because based on your risks, you may not need them anymore. So I put in, I just have an asterisk to myself to make sure that people understand that if there's an abnormal test, these are not the intervals that you would have your testing. You do not have them every 3 years. If there's an abnormal finding, you have to have further evaluation and you might have them more frequently. So we just point that out. The risk factors for cervical precancer and cancer include an HPV infection, of course, and smoking. And it's similar risk factors to other sexually transmitted diseases just because it falls in the same family. So the prevalence of infection, so this is the amount of HPV infection, and this is by age. And you can see there's a peak in this 20 to 24 age group. And that's often when people are sexually active and they may have more than one partner. And so they have risks of exposure to HPV infections. As a person ages, there's actually a decrease in the prevalence. And so we usually see that leveling off. Why we don't this is still in the 20 to 24 age range. 21 is going to fall in this, obviously. We used to do a lot of Pap smears in very young patients when the prevalence was very high. And if you give it some time, and that'll be a slide coming up, most people can handle this infection. Most people can handle and with their immune system. Oh, I'm going to see, hold on. Why does someone oversee? Okay, I will say that in a second. Most people can handle this infection and their own immune system can deal with the HPV virus and not have it be a persistent infection. So if we just give it time in this very high prevalence age, the majority of people will actually get over the infection on their own and not need an intervention. The question in the chat that I saw, I'm going to put the chat up here, is that why does someone over 65 years of age no longer need testing? So I can back up to that slide. Maybe I can, maybe I can't. Okay, so over 65 years of age, if we think about that, the risk factors for HPV infection are multiple partners, smoking, prior persistent HPV infection. Those are kind of your risk factors for precancer and cancer. If you've reached age 65 and you have the serial testing prior to age 65, that's normal and not showing any signs of an HPV infection, and you don't have a new partner or any other new things that could give you HPV infection, then the likelihood of developing persistent infection is very low, and that's why it's not continued after age 65. I think you should qualify that with, as I said before, if you have someone that's 65 and has a long history of an HPV infection, they will not be a candidate to fall off that screening algorithm. They stay on it. So that's just something to keep in mind. If you have someone that has a history of HPV infection, a high-grade HPV infection, or high-grade precancer, excuse me, I'll explain that in 1 second, they will probably need screening almost for the rest of their life. So the abnormal pap smears can fall into low and high grade, and it's the high grade group of people that we are really concerned about. High grade is kind of synonymous with a precancerous finding, and we usually absolutely need more evaluation, and that's going to be coming up. Oh, it won't let me advance. Let's see if I can do it. Oh, it did. Sorry. So persistence of infection, persistence of the HPV virus is what really is a harbinger of problems. So if you are HPV positive and you do not clear this infection, that's a sign that your immune system is not able to identify this as a problem. And it's the persistence of infection that increases your risk of developing precancer or cancer. So if we looked at patients at 1 year, so you have an abnormal pap smear, you have an HPV infection, you do your evaluation and everything looks fine, we find that we'd say we'll repeat the pap smear in a year. And if we come back, we look, the pap smear can actually revert back to normal, and the HPV status also can revert back to negative, because in 1 year's time, the majority of people will eradicate that viral infection on their own. So only 30%, only a third of people will be left with the infection after 1 year. And then if we go into 2 years' time, only 10% will have the persistence of infection. And still, even though 10% seems like it's still a significant number, with the proper screening and with the proper treatment, typically we can, the cervical cancer that results from this persistent infection is still, in the States anyway, less than about 2%. So we still have a very big number of infections, but still a very small number that result in cancer. I will point out that HPV infections, even if they don't result in cancer, are still really problematic. You have to keep coming back for PAPs, you have to keep coming back for the potentially biopsies and colposcopy procedures that were mentioned previously. So there's still a lot of surveillance of an abnormal pap smear. You can develop the other changes that are related to HPV that are non-cancerous, or genital warts. You still can have problems with genital warts, even if you don't have a precancer or cancer, and that requires treatment as well. So there's still a lot of morbidity or side effects, as we think of, from an HPV infection, even if it doesn't result in cancer. That's time out of work, that's time away from family. It takes a lot of time to make appointments, to get to appointments. And so it can still be labor intensive for a patient. So we saw the review of the anatomy, and I just wanted to talk about a little bit what happens if you have an abnormal pap smear. As it was mentioned in the prior presentations, patients that have abnormal pap smears, I think even in the prior presentation, they refer to the L-sil and H-sil. So low grade changes are L-sils, H is the high grade changes. And so if you have an abnormal pap smear, it will be categorized as a low or high grade change. And it typically means that you have to have further evaluation. And that further evaluation is a closer look at the cervix. And how do you get a closer look at the cervix? You have to do a pelvic exam similar to what you would have for when you collect the pap smear, but we actually use this device here. And it's basically a magnifying microscope to see changes on the surface of the cervix more clearly. So we can do what's called a biopsy. So you can do random biopsies, which that was probably done at some point, but they found that it's such a higher yield if you actually look at the geography of the cervix under magnification and then take a directed biopsy. So that's why we do what's called, and this is the procedure is called colposcopy. So it's just looking at the cervix under magnification. So once you get a biopsy, then you'll find out pathology. So that's your result from the tissue. And I want to point out the difference that a pap smear is looking at cells, cytology, but a biopsy looks at tissue. And it's the tissue that gives you the diagnosis. So even if you had a pap smear that was abnormal and showed high-grade changes, it doesn't diagnose anything. That doesn't mean, or even if it said, even a pap smear that said cancer on it is not a diagnosis. You would still want to have tissue because that's actually the gold standard. And that's what would make plans, what would enable your provider to make plans. I could not treat someone just on the cytology alone. I really do require that there's a biopsy and pathology to formulate a treatment plan. So this is a very important step. There is a question, and I'm going to answer that just so I don't ignore anything. Does the virus go dormant or completely clear the body? That's a little bit controversial, actually. It is, I think there's probably a combination of both things, that some people can clear it altogether, and in some people it just stays in check, where they don't have any visible signs of a viral infection, and it's maybe hard to even tell that you have any virus left, but I think it probably is a combination of both of those things. And if that does not answer any, or if there's additional questions, or if that doesn't answer the question, please feel free to ask. So now we have, just to review, we've talked about pap smear testing, pap testing, findings that we could have on the pap test, the evaluation of that abnormal finding with colposcopy. The treatment is going to be based on pathology. And the pathology can tell us if it's a precancer or cancer. Precancers can be treated, and that was also mentioned on the prior presentation. Precancers can be treated with an excision. Actually, I'll go back to that slide, just because I want to point out, like I mentioned, the cervix has length and it's about 4 centimeters. And so with the speculum, you can see the edge of the cervix. And if you had a precancer of the cervix, the next step would be, especially in women that are still of childbearing age or young, we would say we would want to do something conservative, where we excise the end of the cervix, that edge of the cervix, but still leave the majority of the cervix present and the uterus able to carry or bear children. So that was mentioned in the prior presentation, the LEAP procedure. So LEAP stands for Loop Electrical Excisional Procedure. And so that is an excision of just this most distal part of the cervix. And then that is sent to pathology to determine, is it still just precancer? So that's the first thing that they'll look for. And then the second thing they'll look for is the lesion totally removed? If it's not totally removed, sometimes you have to have another procedure. And if it is totally removed, then you can go back to screening or surveillance, which is the pap testing. If you have this history of high-grade pap, as I mentioned previously, you will not go every 3 to 5 years. You will probably need to stay in an annual screening mode until you get serial normal paps, and then you'll be able to go back to the longer interval. So it's important to let patients or people know that it does require more frequent visits if you have a high-grade pap smear and then pathology that says high-grade changes. So if there is a cancer found, and I just put this up, it's really just to impress upon people the degree of HPV morbidity and mortality that's out there. So you don't have to look at all these numbers at all. You don't have to keep track of it. It's a busy slide, but I wanted to point out that this number here, 37,000. So over 37,000 cancers are attributed to this virus. And this is a major source of morbidity and mortality in the US. And this is a country where we actually have good screening methods and extensive healthcare resources. So you can imagine how other under-resourced countries deal with this. It's very problematic. So HPV, just as a sidebar, is one of the most common infections outside of the US. We say 14 million here, but it is even more so elsewhere. And in under-resourced countries, it is a leading cause of cancer. In maybe over 500,000 cancers are attributed to HPV globally. So in this country, we have a very small number, but globally, it is a huge, huge problem. The fact that we even have this number in this country is still very problematic. About a third of these, if we looked up here at the cervix, are going to be related to cervical cancer, and cervical cancer has a very good screening modality, which we just talked about, the Pap test and the HPV test. So it's a matter of getting them out to people and screening more people so that we can still keep this number or get this number lower. Unfortunately, for the other cancers, and the next biggest one is actually oropharyngeal. So that's the back of the throat. There is not a screen for that. But one has to think about if we can decrease the overall burden of HPV in general, that we might be able to impact some of these other cancers too. So that's food for thought. So how would one go about that? Yes, you could try very hard to get more people into screening, and I don't think those efforts should decrease at all. And obviously, with all the work that you're doing, you're certainly in the forefront in this state of getting more people screened. But there is another available resource, and that is the HPV vaccine. The HPV vaccine was rolled out probably in the early 2000s. So it's over 10 years, it's almost going on 20 years of being available, but it is met with a lot of challenges and it hasn't been universally accepted. It is not part of like school vaccination programs. So it's not a mandatory vaccination. It does require parental consent, and it does then take the parents to have the initiative to have this vaccination series completed. So it's an important resource, and I think it's possibly a little underutilized. It's available as early as age 9, but the typical age that it's endorsed is about 11 or 12. And that is not an arbitrary age. That was from studies. It was found that and if you saw my prevalence slide, it was very high in ages 20-24, but it wasn't 0 before that. And so that's why this is trying to be a vaccine that's available before women and boys, before girls and boys are sexually active. So it's basically for all at age 11 or 12. Any known side effects of the HPV vaccine? We will definitely get to that, yes. So this is the current vaccine that's available in the US is the 9-valent. So it's Gardasil 9. There's been 2 other vaccines available prior to this, but as of like 2016, this is the vaccination that's present in the States, and it's the only one given in the States now. So you might have heard of Cervarix or Gardasil 4, the quadrivalent, but they're not actually given anymore in the States. So it is developed by Merck. These are the subtypes of the vaccine of the HPV virus that's included in this. So HPV viral types 6 and 11 are predominantly associated with genital warts. And then 16, 18, 31, 33, 45, 52, and 58 are ones that are associated with cancer. 16 and 18 are responsible for the majority of cancers in the US. And so those are bolded there just to remind me to say that. Hypersensitivity to yeast is one of the only contraindications because this vaccine is developed with yeast components. It's made a very similar way as the hepatitis B vaccine, and that is given to infants. So, you know, it's made in a very similar method. It is given in a series, and it's typically 0, 2, and 6 months, but there's some caveats to that, which I'll talk about in a second. The main morbidity or the main side effects from the vaccination has been found to be local, as in arm swelling, arm pain, soreness. There is this caveat of once a person is vaccinated, they need to wait for 15 minutes to make sure that there is no, there's been some associated fainting with this vaccine. And it's hard to say if that's because of the age group that it's given in. We're talking about preteen and teens that are mostly getting this, and that may contribute to fainting. It is in a different age group than typical vaccinations, and that makes it a little bit challenging to administer because teenagers are not, they're not really getting a lot of as many well visits as infants and younger patients. And so it's a little bit harder group to capture. So this is the routine schedule. So as we mentioned, 11 and 12, it can be started as early as 9, but typically it starts 11, 12 years. 13 to 26 are thought to be your vaccination catch-up years. And then with shared clinical decision-making, this is probably about a 2-year-old recommendation now. Some adults are eligible to continue to receive the vaccine up to age 45 if you haven't been vaccinated previously. And that shared decision-making is really a conversation with a person and their provider, because it's possible that you could have missed your vaccination, but you might have risk factors for the HPV viral infection. You might be a smoker, you might have had prior abnormal PAPs, or you might have had prior high-grade cervical dysplasia and be outside of this age of 26. So you might be a very good candidate still for the vaccination. This asterisk is just to point out that if you receive the vaccine or if you initiate the vaccine before age 15, only 2 doses are needed. And that is helpful because the 3-dose series is part of the problem with the vaccination, is that it's hard to complete 3 vaccines in any population, but it's been found to be particularly challenging in this age group because, again, they don't come for regular visits as much as younger patients. This vaccine can be given if you are in for a sick visit, or, you know, if somebody has a cough and they're being evaluated. The vaccine can be given, and it can be given with other vaccines as well. So there's still the Tdap, the meningococcal, there's still other vaccines that patients in this age group might receive, and it can be grouped with that. It can be given at the same time. So those are just things to keep in mind. It does require parental consent, as I noted. So if another person brings the patient in to the clinic, it still can sometimes be missed because they need to have parents' consent to the vaccination schedule. I think it was initially hampered a lot by being associated with sexual activity. And I think that might hamper its acceptance because I think parents worried, and this has been studied a lot, but it hasn't been found to be true, that people worried that if you were talking about a sexually transmitted disease and a vaccination in a young population, that you might increase the risk of them being sexually active. But that was not found to be the case. And there's been several studies about that as well. I'm going to read the questions. So 1 second. What percentage start but do not complete the series? And what type of protection does a single dose give? That's a really good question. It's hard for me to know how many don't complete the series because you actually can, if you, it would take a long time to know if they never got it, because you can complete the series if you're outside. Granted, we said like if you can get it first less than age 15, then you get the first dose at time 0 and the second dose in the next 6 to 12 months. So that would be a completing of the series. As it turns out, if you miss your second vaccination, you can still get it even if it's much later. So it'll be hard to know exactly how many don't complete at all, because you still get a very wide window to complete the vaccine. So if you started it at age 11 and you just didn't come back, if you came back at age 14, you could still get that second dose. What type of protection does a single dose give? Also, excellent question. And I will point out that there is data that shows one vaccination dose gives a lot of protection, actually. Maybe, I mean, in the non-sexually active population, this vaccination, the efficacy was thought to be close to 100%, meaning that if they got tested, if that in the studies, there were tens of thousands of women initially in the studies, they had 0 HPV viral antigens initially. After vaccination, almost 100% of them seroconverted. So that means that they all had a response. If you've had partners and you've had exposure to HPV before, then it's a little bit different, because your body will do some and the vaccination will do some. So it's a little bit split. The CDC guideline is still to complete 2 to 3 doses, depending on your age. But the World Health Organization actually says that 1 vaccination, 1 to 2 doses, is actually sufficient for anyone less than 21. They have a different guideline than the CDC, and being in this States, we're going to follow the CDC. But worldwide, 1 vaccination is still thought to be like at least give you sufficient coverage to protect you from most HPV viral types. The 9 that are oncogenic, that are within this vaccine, they're not the only viral types out there, but they are the bulk of the ones that are associated with cancer. So the coverage from 1 dose, bottom line, the coverage from 1 dose is still quite excellent. It's just that we haven't evolved yet to just allowing 1 dose, but I think it could be coming. I think that would be a really nice thing, because I think completing the series is a hurdle for a lot of people, and we don't want to set up hurdles. We want to take those hurdles down. Would receiving the quadrivalent HPV vaccine be considered not adequately vaccinated? Very good question. So that has been debated, but the current standing is that if you've completed the quadrivalent series, it is not recommended that you come over the top of that series with the HPV-9 vaccination. And probably it's because that 16, 18 were present in the HPV, in the quadrivalent vaccine. And again, that's over 75% of the cancers of the cervix are going to be from those 2 viral types alone. So it's not thought that there's an appreciable significant increase in coverage just to get the other 7 types. So just as a thought. And 6 and 11 were also present in the quadrivalent, because those were the 4 types, 6, 11, 16, 18. And since that's the majority of where the morbidity and the mortality come from for HPV infections, the remaining 5 were not thought to add a significant benefit. Just to answer that question. So at this point in time, in the States, I'm going to go ahead 1 and come back. So I guess it's not. I want to show something. I want to skip around a little bit. In the States right now, about 6 out of 10 people are getting the vaccine in the correct age, in the proposed age group. So that was well short of the healthy people goal of 2020, which was hoping to get people maybe 80% vaccinated. So we fell short of that by quite a bit. And I think it's even now probably plateaued, because vaccinations have become so controversial. So it's been tricky to get any vaccination program rolled out, as you might imagine. Wisconsin does pretty well, actually. If you see, we're in the 60 to 69%, and that's pretty significant. Where it is the darkest, you'll notice a lot of those states, it's mandatory, and that's what's helped them achieve better vaccination rates. So I'm going to go back to this slide. I like that picture. I should have moved it ahead. But at this point in time, what we know about the vaccine, after almost 20 years of use and over 100 million doses, is that it is having an impact. So this is a lot of words on this slide, and you'll get all the slides, I imagine, but just to summarize, at this point in time, with women and girls being tested, we are noticing fewer precancerous lesions and fewer genital wart infections. So that is a very, very positive sign that even with the coverage that we have, things are moving in the right direction and there's progress being made. As it turns out, with any vaccine, and as you've heard, I'm sure with COVID and any vaccination programs, the more people that are vaccinated, the more the benefit spreads. So of course, that's all great. That when I said, when I noted there that 88% of genital wart infections have decreased in teens, that's really great. But the more people get vaccinated, we could have the potential of eradicating that. And so it's really hard for me as, and warts are not even a cancer, they're not even a precancer, but they certainly do cause a lot of morbidity for people. And then that means that they've also been exposed to the same, they've been exposed to the viral types that do cause cancer. And so that's where I get concerned, is that you probably can't emphasize enough that there's an association with cervical cancer and other anogenital cancers and this virus. And we actually have something, in addition to pap smears for screening, but we actually have something that is showing early signs of working to decrease the viral presence in the community. Why you can't say that the cancer rates are lower is because of how long it takes to develop cancer. An infection from HPV evolves into cancer over many, many years. So the infection happens, let's say if you took a woman's course, if the infection happens at age 25 and they develop an HPV, they are sexually active, they have exposure to HPV, and they have a viral infection. And if they don't clear it in the first 2 years, so that's 10% of people, we said, where do they get cancer? They actually don't get cancer for many decades later. They have, your patients that you had in your presentation had ages of 40 and 49. So where do you think they got their infection? They probably had their infection in their 20s, like everyone else. And then they evolved with precancer changes. That takes several years, maybe a decade or so. And then cancer is in their 40s. So that particular population is a really sensitive one for us as oncologists, because I'm used to dealing with people who are older patients, they're postmenopausal, they've, they don't have young children anymore, and some of them are even not working anymore. But the 40-year-old patient with advanced cancer is a pretty difficult scenario for everyone, as you might imagine, and it's a really different age group. But it's because of the natural history of HPV and how it evolves over time. That's where they unfortunately arise with cancer, is that it's screening. If screening hasn't happened early on and they're not caught with the precancer, over decades, persistence of infection will evolve into cancer. So if you're exposed in your 20s and you don't have screening in between, unfortunately, even though it's only a few percent, it's still significant enough. We already said 4,000 deaths in the US with a screening exam and a vaccination. And so that's a big deal. That these are all preventable in a way is part of the heartbreaking part of it too, which you discussed in your other presentation. These are people that are young, they still have young children, they're still working, they're still contributing, and they have a devastating disease that could have potentially been prevented. So it's challenging. This is the climate that's very hostile to vaccinations right now. And I think it's okay for people to be skeptical and, to ask questions. But you really, once they get very negative feelings towards vaccinations, it's really, really hard to overcome. So we just ask that people stay open-minded, that people hear both sides, that they hear about the benefits. They have to make their decisions on their own, of course. But I think what they often do is make the decision maybe without all the information, but having as much information as they can might help them make a decision that would be beneficial for them and their families, which I hope would include vaccinating their children. So it's multiple doses. It's a difficult population. It is associated with vaccine hesitancy as everything everything vaccination is related is. It does require parental consent. And there is, of course, concern regarding side effects and safety. But at this point in time, there is tens of that. So at least 50,000 women were initially involved in all the studies. And we have over 10 years of surveillance from this vaccination. And there are no major side effects or safety signals outside of the same ones that we have for hepatitis or meningococcal or Tdap. They are very, very concordant, all of them. And yes, you will hear in the news that there's a terrible effect and, it's possibly associated with the vaccine. That always makes the front page, but it never makes the front page again once it's been investigated. And if it's been debunked, that doesn't make the news anymore. And so that negative association is what stays with people. So we have to just try to see if we can, just as you were saying before, you have to meet people where they are, and they need to have the information where they are so that they can help them understand the pluses and the minuses of it, but can't let the negative news override the potential positives. And I'm hoping that people can see that there is more information than what just hits the front page. Also want to point out that if you have the HPV vaccination, that does not mean you don't get Pap testing anymore. That's a really important point to make sure that people understand. You don't get the buy just because you've had the vaccination. You still have to remain in screening because you want to, the vaccination is there's nothing that's 100% protective for viral infections. And so you still want to make sure that you get your screening and get the proper treatment if there's any abnormalities found. Let me see, there's another question. Do you think there is benefit to getting the vaccine after a known high-risk exposure? I do actually believe that. Of course, there is shades of gray in all of this. So the ideal population of the studies that were done when this vaccination was being studied were people that had never had sexual intercourse before and had no HPV viral type exposure. If you've had intercourse and have had viral type exposure, there is potentially still benefit for you because you may not have been exposed to all 9 viral types with intercourse. You may only have seen a few. So there is potential if you're non-vaccinated, meet the criteria to think about vaccination, even if you're in the catch-up or older age group, because you could still have viral types that the vaccination could boost your immune system against. And those were the last words. I kind of already said them, that at this point in time, what we know about the vaccination is safe, and what we know about the vaccination is effective, and what we know protection-wise is very long-lasting. And these are some QR codes if people want to get more information. These are both government sites to provide information, the CDC and then cancer.gov. And you can scan those QR codes, or you could just Google it online. I think that's my last slide. Yes. Any other question? Oh, okay, back to that. Going back to if the virus goes dormant or clears, is there any published research on if stress impacts activating the virus? Thinking of normal PAP with positive HPV. So normal PAP with positive HPV, actually, I will just address that first and then I'll go to the question. Normal PAP with positive HPV, actually, I think you can, if that is consistently found, you still actually should revert to colposcopy and potentially biopsies. So that still gets a full evaluation, because you want to make sure that, because PAPs are not 100%, that you could miss something on a PAP. So you can't hang your hat on any one thing. And that's why co-testing is actually so helpful, is that it's like a double net, but you still want to make sure you do the full evaluation. So that's one side of that question. Does stress impact activating the virus? So that's a really tough one, because I think there is some camps that do believe that that's possible. I think we probably don't know enough. But if you think of it similar to like shingles, That's thought to be brought out by stress in individuals, and that's a dormant viral type that is then exhibited under pressure in some people. So I can't rule out that that's possible because the immune system seems to have many mysteries that we still do not know about. And so, as thought with cancer and other, like I said, shingles, there is a very significant immune connection with defense of infection. So I can't totally answer that question, but that's because there's still so many questions out there about that. Next question. Thank you for all the questions, by the way. I appreciate it. It takes me off of the slides for a minute. So best practice for follow-up on an abnormal cervical cancer screening that needs maybe yearly follow-up instead of every 3 years. Do you have dedicated staff follow up on these, run reports, send MyChart messages automatically to make sure patients are following up? That's a really good question. So initially, we would say, yes, there is. The office follow-up will be kind of available or present for the initial, once somebody has an abnormal PAP. I would say, I can't say what all offices do. This is what our office does, but I will qualify it with, I don't treat the majority of abnormal pap smears because that is often happening in general gynecology, not in the cancer office or clinics, because they've already passed through all that by the time they've come to see me. So I will say that. In most offices, I'd say there are probably reminders for the initial, maybe the initial 6 months to 12 months. But I think there's definitely people that fall through the crack because there aren't reminders out to like 5 years. So if you miss it after your first year and you just don't come back, I think that is a really hard thing to flag and catch. The appointment will be set up for you, but people often just may not come for the appointment. And then once they don't come for the appointment, that'll flag it to me that I have to call the patient back and make a new one. But if we attempt to contact the patient, usually it's probably by like 3 times. If there's no response or no rescheduling, that is actually how people will fall off the radar for me in my clinic. If they don't show up for procedures and things like that, where I know that they have either a high grade biopsy or cancer, I actually end up sending a certified letter to them so that they know this could be life-threatening. Full disclosure, this could be life-threatening. This is not recommended to not address it. And then there's probably not a lot I can do because these are adults, unfortunately, and I can't make them. I have people that have had diagnoses of cancer that have decided they did not want treatment, and then I feel like I might be harassing them if it gets a little too far. So I can't do that. Any other questions? I hope that helped. I hope that makes sense. I think this viral type and the evolution of cancer from this viral type or viral types is very interesting, that it's a slow process. It happens over time. And that's why that's why there is a screening test. So if you had a cancer that grew in a flash, there would be no point in screening them. There would be no window of opportunity to catch them before they developed cancer. But the evolution of this viral infection is kind of a slow process for most people. And there's that window of time you can catch someone before they get to cancer. And that's a very important window. It is a huge amount of resources that are spent on cancer when we have a resource that could help pre-cancer and treat something earlier, smaller, with conservative therapy, and could still save. That's an important step. It saves lives. So the work that's being done by the Cancer Collaborative is pivotal.
Thank you so much, Dr. Uyar. You did such a wonderful job answering questions as we went too. So I think we have addressed all of them. We just really appreciate you taking the time to be on today. Shared so much wonderful info.
Sorry, I think we went a little over, but thank you very much. Thanks for everything.
Thank you so much. And so before we conclude today, I'm going to launch just a brief poll, if you wouldn't mind taking that for us. We really appreciate your feedback. And I also wanted to highlight a few resources that we have available on our WCC website. The first one is our cervical cancer how-to sheet. So our how-to sheets offer straightforward answers to questions about cancer risk, screenings, insurance coverage, so that patients can make informed choices about their health. You can use these tools to start important conversations with patients, families, and community members who might have health literacy differences. And this one is available in both English and Spanish and was actually created in partnership with the Wisconsin Well Woman program. And I believe that link is dropped in our chat. The next one I just want to briefly highlight is our HPV-related cancers and vaccination coverage in Wisconsin issue brief. This was put out actually just about a year ago. These are really great tools that you can use to educate decision makers or also align your work with the latest research. And lastly, I want to conclude with a few exciting announcements that are coming up within the Wisconsin Collaborative Program. We do have a member orientation webinar coming up on March 2nd. This is a really great opportunity if you are looking to join the Wisconsin Cancer Collaborative, or maybe you have been a longtime member and just need a refresh on what it offers. We hope you will join us on March 2nd. We're going to cover many of our different resources and how to use our membership networking directory, and talk about a lot of the other really great features that the membership offers. So you can feel free to register for that at the link. And if you aren't a member and would like to join before this webinar, you can do so also at that link below. And lastly, we are so excited to announce that we have the dates and locations secured for our 2023 Wisconsin Cancer Summit. So we hope to see you in the Dells November 1st and 2nd at the Wilderness Resort. This year's summit is going to build off of last year's theme, the power of story. So this year we are going to take a look at how we can put those stories into action. So this year's theme is the power of action, putting cancer control into motion. Be inspired by the work and stories of people in your community and learn about your role in the cancer plan and how to improve health outcomes in Wisconsin. So stay tuned because we will be sending out more information in the next coming months. And the very, very last announcement is we are so excited that we are bringing regional meetings back after several years. I know we were so close to getting on the road right before COVID hit. So we are excited that we are finally going to get back out around the state. So these will be happening this spring. And again, more information will be coming about those. Thank you again so much for attending today. We appreciate you taking the time out of your day. The recording and slides will be made available after this. So it will be coming to your inbox. So be sure to be on the lookout for that. And it also will be posted to our website. Thank you again, and we hope to see you in March.